Good afternoon, everyone. I'm doing a technology check-in. Can everyone see and hear? If at any time you lose any audio, please send a message through the chat feature on the webinar. We will be muting everyone's phones. However, there will be several question and answer sessions throughout the presentation where we will unmute the phones. You can also type your questions using the chat feature at any time. Welcome, everyone. Today we will be discussing the California Department of Social Services' recent psychotropic medication data sharing efforts. I'm Alicia Sandoval. I'm the Chief of the Child Welfare Data Analysis Bureau in the Research Services Branch, and I will be facilitating today's presentation. First, I'd like to introduce you to the presenters for this webinar. We have Lori Fuller, who's the manager in our Foster Care Support Services Bureau. Jennifer White, who's a researcher in our Child Welfare Data Analysis Bureau. Erica Pixon, who's a manager also in the Child Welfare Data Analysis Bureau. And Akhtar Khan, the Chief of our Research Services Branch. Before we get started, I just wanted to go over some housekeeping items. As I mentioned before, your phones are muted. There will be several question and answer sessions throughout the presentation where we will unmute the phones. However, again, you can type your questions in the chat box at any time. If you need to share detailed information with us, you can also send emails and we'll respond promptly. You can send emails that are related to data files you received or any type of data exchange questions to the cwsdata@dss.ca.gov mailbox. And you can send any policy-related emails to qipsychotropic@dss.ca.gov. Today, we will be providing you with some background information on our data sharing efforts. The purpose of today's webinar is to provide counties with guidance and information on recent data sharing activities with psychotropic medication data. These activities include new psychotropic medication measures, county reconciliation reports between JV-220 court authorizations and pharmacy-paid claims, and lastly, the global data sharing agreement between the Department of Healthcare Service, CDSS, and counties who choose to opt into the agreement. I'm going to turn this over now to our first presenter, Lori Fuller, who will go over the background of these efforts.
Thank you, Alicia. Good afternoon, everyone. Before we get into talking about the details of data sharing, wanted to provide everyone with a little bit of background on how we began working on the quality improvement project for psychotropic medications for children in foster care. Wanted to just tell you a little bit about some of the federal legislation that preceded the beginning of the project. In 2008, the Fostering Connections to Success and Increasing Adoptions Act of 2008 required states to develop a plan for ongoing oversight and coordination of healthcare services for children in foster care. And then in 2012, the Child and Family Services Improvement Act required states to specify protocols for appropriate use and monitoring of psychotropic medication for children in foster care. Also in August of 2012, the Administration for Children and Families, the Centers for Medicare and Medicaid Services, and the Substance Abuse and Mental Health Services Administration held a summit in Washington, D.C. The purpose of the summit, which was titled Because Minds Matter, was to offer strategies on cross-system approaches to improving mental health and well-being for children and their families that are evidence-based and use evidence-informed interventions. These strategies were meant to enable states to facilitate the development of action steps to improve upon and implement their existing oversight plans. Additionally, there was many research studies that were conducted which led the federal government to encourage and require states to develop appropriate oversight and monitoring plans. One of the most prominent was in 2008. California participated in a 16-state study, which was conducted by the State Medicaid Medi-Cal Directors Learning Network and Rutgers Center for Education and Research on Mental Health Therapeutics. The study was conducted to identify possible safety and quality issues surrounding antipsychotic drug use in children and youth. The results indicated that California foster children were 5 times more likely to receive psychotropic drugs compared to non-foster care children. And of those children, more than half were prescribed 2 or more psychotropic medications at the same time. So this federal legislation, along to the research and many activities that were going on throughout the country, led California to begin the Quality Improvement Project. The QIP is a collaborative effort between the California Department of Social Services and the Department of Healthcare Services, and our purpose is to explore, identify, and support effective strategies in overseeing and monitoring the use of psychotropic medications of children and youth in the foster care system. Another important feature that has been developed as part of the QIP effort is the execution of a data sharing agreement between the California Department of Social Services and Department of Healthcare Services. As a result of this data sharing agreement, CDSS is able to match CWS CMS with DHCS Medi-Cal Managed Care and Fee-for-Service pharmacy paid claim records for all children in foster care ages 0 to 17. The data reports that can be produced from this matched data have not been available elsewhere and can be used as a tool by the state and counties to inform policy and practice decisions. Additionally, the data can be extracted without requiring any additional data input as they're extracted from already existing data systems. Now on your screen you can see some of the goals of the QI project. Just wanted to provide everybody a little bit of context before we get into more details about data sharing. The goals of the QIP project are to enhance psychotropic medication safety by ensuring that youth in foster care receive appropriate psychotropic medications and that they're prescribed in dosages that are safe for their age, etc. Another aspect, another policy that has been developed by Department of Healthcare Services is the Medi-Cal treatment authorization request process has been expanded to all children receiving antipsychotics from 0 to 17. Previously, this requirement was only in place for children ages 0 to 5. Another goal of the project is to improve the court approval process, the JV220 process. And as part of the project, we're partnering with Judicial Council to make some suggestions and recommendations and try and help them implement some improved practices that will expedite the JV220 process. We're also have a goal of supporting the use of psychosocial interventions in lieu of medications, want to increase the availability of other non-medication strategies, hoping to reduce inappropriate concurrent use of multiple psychotropic medications. We also think it's very important to engage medication prescribers in the practice change, and there's been development of some guidelines information that have been disseminated to prescribers in the field. Also, as with all of the Department of Social Services efforts, we want to engage foster care youth in their care, and part of the project has developed some educational materials that are going to allow foster youth to be more informed and have an active role in deciding about their medication usage. And lastly, which is most relevant to today's topic, is that we wanted to use data to analyze, monitor, and oversee improvement in the safe use of psychotropic medication. On your screen now, you can see some additional resources. If you want some more information about the QIP project, you can go to the Healthcare Services website. This is where you can find information about some of the deliverables, some of the documents that have come out of the project, and obtain additional information about becoming a part of the work groups if you're interested. It is also where we will be posting the recorded version of today's webinar. Additionally, CDFS is in the development of a website, and this webinar will be posted there upon its completion. Also wanted to point out that we've issued several all-county information notices related to the use of psychotropic medication for children in foster care, and those are listed here for you. The first, I-69-13, provided a general background and overview of the issue and the project's development. More recently, we've issued I-3015, which provides information regarding the data reconciliation reports which counties have begun to receive, and you'll hear more information about that later in the presentation. And lastly, I-3615 provides additional information about other kinds of data reports, including the reconciliation reports and the psychotropic medication measures, and it provides some best practice suggestions and information for how counties can develop additional oversight and monitoring strategies within their organizations. I'm now going to turn it over to Jennifer White, who will be discussing the psychotropic medication measures.
Good afternoon. As Lori mentioned, through CDFS's collaboration with DHCS, we are now receiving Medi-Cal managed care and fee-for-service pharmacy paid claims data for youth in foster care, identified through Medi-Cal 8 codes. We take these paid claims data and match them with CWS CMS information to identify dependent youth. With input from stakeholders, 3 QIP, counties, and others, CDFS developed 7 new data measures. These measures are the state's efforts to improve monitoring and oversight of psychotropic medications. With data that was previously unavailable, the department hopes that counties can use these measures as a tool to improve case management and improve county policies and practices. So we're all familiar with one existing state measure for psychotropic medications, which is Measure 5F, Children Authorized for Psychotropic Medication. Here's a list of 7 newly developed state measures ordered by priority. As I mentioned, these measures were developed through stakeholder input, but are based on federal measures and informed by clinical research and data. And the first 2 measures, Measures 5A1 and 5A2, use of psychotropic and antipsychotic medications, which I'll be going over in more detail, is our baseline measure and provides accounts of use identified through paid claims data on psychotropic and antipsychotic medication. Because of risks associated with multiple medications at the same time, Measure 5C, use of multiple concurrent medications, was developed to identify use on multiple concurrent medications with identifiers for youth who are on 2 or more psychotropic medications at the same time, 2 or more antipsychotic medications at the same time, at least 1 antipsychotic medication at the same time as a psychotropic medication. And the 4th measure, because antipsychotic medications sometimes have serious side effects such as weight gain, diabetes, and metabolic disturbance, Measure 5D, ongoing metabolic monitoring for youth on antipsychotic medication, was developed for those with ongoing antipsychotic use and addresses the need for continued monitoring of medication side effects. This measure identifies youth on 2 antipsychotic medications on different dates of service and who had both a test for cholesterol and a test for blood glucose. Measure 5E, use of first-line psychosocial care, encourages use of psychosocial intervention as a first-line treatment for children in whom antipsychotics are not indicated. This measure identifies youth who had a documentation for psychosocial care 90 days prior to or 30 days after the new psychotropic prescription was dispensed. The next two measures assesses receipt of services for youth who initiate treatment. Measure 5G, follow-up visits for youth on psychotropic medication, identifies youth who had a follow-up visit with a practitioner with prescribing authority within 30 days of the new psychotropic prescription was dispensed. 5H, metabolic screening for youth newly on antipsychotic medication, establishes baseline functioning before medication side effects begin. This measure identifies youth who had one or more tests for blood glucose or cholesterol 90 days prior to or 15 days after the new start of an antipsychotic medication. I know that was a lot, but I'll be going over more detail about the first two measures. And over a little over a week ago, on Monday, July 27th, County Child Welfare Directors and Chief Probation Officers received a one-time transmission of measures 5A1 and 5A2, use of psychotropic and antipsychotic medications, via an encrypted, password-protected file of two Microsoft Excel spreadsheets containing a list of case IDs of youth who we've identified through the CDSS and DHCS data match of youth who are on psychotropic medication and youth on antipsychotic medication during the 12-month period between April 1st, 2014 through March 31st, 2015. These data are protected by privacy and confidentiality laws because of the medication information they contain. So the email instructed counties to call one of two phone numbers to retrieve the password for the encrypted file. So the methodology, through stakeholder collaboration, the data are limited to dependent youth in foster care for at least 30 days, youth under 18 at the paid claim date, and excludes youth placed in non-foster care placements such as medical facilities, ranches, juvenile hall, regional center placement homes, and also includes non-dependent guardians. Beginning October 1st and each quarter thereafter, de-identified aggregate information will be made available on the Berkeley website. That's the website projected on the screen. The additional measures we discussed will be forthcoming also and be posted on that same website.
Thanks, Jennifer. You have shared quite a bit of information, and I think this is probably a good stopping point for questions. So we're going to go ahead and take everyone off mute, so if you can give us a moment to do that. And also, just to remind you, you can also use the chat feature in the webinar to type in your questions.
Did you see that?
I think you can unmute yourselves also. As an attendee. Are there any questions on the chat?
Do we have chat questions?
The chat question we have is they're asking us when the slides will be made available, or if they'll be made available.
This webinar is being recorded currently, and so the recording and the slides will be made available on the DHCS website and the CDSS website that's under development. And when? Soon. In the next few days or so.
Yeah, it should be within a week. We'll have it posted. We're still working on the unmuting, if you can give us a moment.
Oh, okay.
We have a question?
Yeah, actually you're unmuted.
It says on.
If you click raise your hand on here and you have a question, I can unmute you faster.
Is there a raise your hand button?
There is. I just don't know how to press it.
If you have a question, please speak up and ask. We're slowly unmuting everyone, but we have a lot of folks on the call.
Okay. We have a question here in the chat box. The material states youth under 18, but what about non-minor dependents?
Well, for the measures, our measures are limited to youth under 18 currently, and that was developed through the stakeholder process, the county partnership process, through the data committee, and the QIP work group. data available, which we'll be going over through the global data sharing agreement, non-minor dependents can be included for other types of data not included in the measures.
To give a little additional information, the focus of the project has primarily been on youth under the age of 18, primarily because the court authorization is required that those minors to receive the psychotropic medication, whereas when they become non-minor dependents, they are able to consent to medication use and make decisions about their medication. Somebody on the phone have a question?
Well, we have another question. How is data for lab tests collected?
It'll be collected through HDS's billings data. So there are no additional data entry requirements for counties with any of these measures.
Hello, Alicia. Can you hear me?
Yes.
Hi, this is Lynette Scott from DHCS, and I just want to clarify that for the laboratory data, what we have in our system is the fact that that was billed for. We don't necessarily have the results of the laboratory monitoring. So this is more a measure that takes into account that the lab test has occurred. At the local level, you would then need to be in contact with the actual providers to get at the results if that was something that you needed to look at.
Thank you for that clarification.
Any other questions?
There's the next question is, what if our local county council does not agree with the global data sharing agreement?
Yeah, we're going to go over the details of the global data sharing agreement in a few minutes, and we will be sure to answer the question at that point. Do we have any other questions that are specific to the psychotropic medication measures?
We have another question. Lisa Sorensen asks, will the de-identified data posted on Berkeley's site be password protected or available to the public?
Because the data are de-identified and aggregated, there is no need for password protection. And yes, it will be available to the public.
Any other questions?
Yes, I do have a question. For those counties that opt in to receive the additional reports, what will that include?
We'll be going over the details of the global data sharing agreement, including data elements and available data in the third part of the presentation.
Okay, great. Thank you.
I know that there's a lot of questions on global.
We're almost there.
If there's any additional questions on the background of the project or the data measures, I'm happy to answer them at this presentation.
The next question we have is following the QRP mandatory for all counties in California? By Jennifer Stolmiller.
I'll take a stab at that one. It's being part of the project is a voluntary, not a requirement in any sense. However, I believe that all counties would benefit from receiving information on being part of the development of the project. But no, it is not a required.
Next question is, can you repeat the date the measures were sent in the encrypted email? And this was emailed to the Chief Probation Officer of the department.
They were emailed to County Child Welfare Directors and Chief Probation Officers Monday, July 20th. A file contains one file with 2 spreadsheets and 2 additional Word documents, methodology for each.
Psychotropic. Okay, the next question we have is, if the psychotropic is identified as misuse, what do we do?
I think we need a little more information we can answer that question. And you say identified as inappropriate, specifically by whom. This data isn't necessarily going to provide any information about witnesses of medication. It's only going to provide information about what medications have been prescribed and whether they've been authorized. So if whoever asked that question can type in more contact answers there.
Okay, we're going to go ahead and move on the presentation, and again, we're going to be stopping periodically for Q&A session. So next on the agenda is Erica Pittsman, who will be discussing the county reconciliation report.
Hi, good afternoon, everybody. I just wanted to discuss a little bit about the county reconciliation report.
Sounds like there's a lot of background noise, so if you can just give us a moment trying to deal with that technical issue. Hold on one sec.
Hi, everyone. Again, this is Erica. So I'm going to be discussing the county reconciliation reports, which are reconciliations of the JV 220 court authorizations against the DHCS paid claims. So yesterday, for the second time, child welfare directors received an encrypted and password-protected file that identified youth through case IDs who received a paid claim for psychotropic medication for Q1 2015, which is January through March, and these did not have a preceding JV 220 authorization documented in CWS CMS. Child welfare agencies received their first report on May 8th and will continue to receive these reports on a quarterly basis. The report currently excludes probation supervised youth. However, CDFS has been in discussion with and will be distributing these reports to probation in the near future. I also wanted to go into a little bit about the methodology for these reports. So we first wanted to note that although legally the JV 220s are considered valid 6 months from the authorization date and must be renewed every 6 months thereafter, for purposes of this report, they are considered valid 12 months following the court authorization date. This 12-month time frame was agreed upon by stakeholders and county partners to allow for things such as court continuances and other case delays. JV 220s are considered valid for these reports if court consent dates are dated on or precede the paid claim date by 12 months. We also would like to acknowledge that there are some limitations to this report. For instance, there may be instances where the authorizations are dated after the paid claims, which have perfectly good explanations, such as emergency situations, or when youth enter care with an existing prescription. There also may be authorizations that are dated beyond 365 days prior to the claim that possibly haven't been updated in the system. Also, at this time, we are not able to reconcile the medication-specific court authorization. We also want to recognize that there may be alternative documentation of a valid court authorization, either in a hard copy file or an external data system. However, given that CWS CMS is the official statewide child welfare case management system, this data is what is available to the state to share with counties. So now I wanted to go through an example of what the reports look like that were sent out. So this is an example of a county report that has been emailed to county directors with one child listed. So counties receive a file with a list of case IDs that identify youth who received at least one paid claim for psychotropic medication, and they have no preceding court authorization in CWS CMS. As a county, your first step would be to go into CWS CMS and look at the case records for that youth. For a youth on one medication, this reconciliation process may be fairly simple. You may find that there is in fact no authorization documented or in the file, which would then warrant further discussion with the youth care provider. However, you may see, as in this instance, Susie has a court authorization documented in CWS-CMS, and you would wonder why she's included in the report. So we want to explain why. CDSS may receive information from DHCS, for example, in this case, that the paid claim was received prior to the court authorization date, and that's why Susie's included. Other instances where a youth would be included in the report where you have an authorization in CWS-CMS is that the authorization date is more than 365 days prior to the paid claim. So the instances are going to be where you're going to have either you're not going to have a documentation in the system and you want to talk to the care providers, or you may see a court authorization in file that is either old or does not precede the paid claim. The second example that's on the screen is a little more complicated situation where a youth may have more than one authorization listed in CWS-CMS. As described before, the county will receive a list of case IDs from CDSS that indicate those youth do not have a valid JV-220 documented prior to receiving the psychotropic medication. In this instance, when you look at Johnny's case, you would see that he does in fact have an authorization and actually has two. But what CDSS can see via shared data and determine is that Johnny received two medications. In this case, he received an antipsychotic and a psychotropic. So while the March authorization is in fact valid because it was dated prior to the paid claim, the January one is not because it's over a year old, and that's why Johnny's included in the report. Now, CDSS recognizes that without medication-specific information and dates, especially for use on more than one medication, these reports can be challenging to reconcile with your county records. The hope is that these reports can be a tool for case management and provide you a flag so that to indicate that something should be investigated for this case as it pertains to psychotropic medication. However, counties can be party to this individual client-level medication-specific information by opting into the global data sharing agreement that currently exists between CDSS and DHCS. Counties that enter into the global data sharing agreement will be able to receive data containing confidential information pertaining to youth receiving child welfare services in their county. And OCTAR-CON will be providing more information on the global data sharing agreement.
Thanks, Erica. We're going to go ahead and stop now just for a few questions that we received through the chat box.
Well, we have a couple of individuals who have their hands raised, so I'm muting their phone. We have Craig Demers and David Patrick. Do you still have questions?
Oh, no, I'm sorry.
We can barely hear you.
I'm good. Sorry. I'll lower my hand.
Oh, okay. Did we have another question out there? Nope? Okay.
All right. Thank you.
Let's go ahead and move on. Next on the agenda is the Global Data Sharing Agreement. OCTAR-CON, please take it away.
Okay, thank you very much, and good afternoon, everybody. My name is OCTAR-CON. I'm the Chief of Research Services Branch here. I will be talking about Global Data Sharing Agreement in a little bit more detail. As my colleagues Erica and Lori mentioned, a Global Data Sharing Agreement has been executed between Department of Healthcare Services and Department of Social Services on April 9, 2015. And ACIN, as it has been mentioned, ACIN number 13615 was sent to all counties to this effect on May 12, 2015. The global part of this agreement refers to an open exchange of individual client-level information between the CDSS and DHCS, counties and tribes that opt into this this agreement. Individual child-level information can be made available to counties by entering into this global data sharing agreement that currently exist, as we spoke before, between two departments, social services and healthcare services. County child welfare agencies that enter into global data sharing agreement with CDSS and DSCS will be able to receive data containing confidential information pertaining to the children or non-minor dependents receiving child welfare services in the county that opt for the global data sharing agreement. The data received by counties that opt into the agreement would include the data derived from CWS CMS and medical paid claims data match. Although the global data sharing agreement is not restricted to QIP only, Psychotropic Meds project, however, in the context of QIP, this individual child level information is an important tool to monitor the use of psychotropic medication by children in foster care. In summary, the benefits of opting into global data sharing agreement include ease of access of confidential data by all counties to use, and it is all cost-free. There's no cost attached to it. And there was a question about if counties are not opting into the global data sharing agreement, then what is the route for them to receive confidential data? So alternatively, county child welfare and probation agencies may wish to explore data sharing between their county behavioral health agencies and the Department of Healthcare Services as a separate agreement. So that is the alternative to not entering into global data sharing agreement. So now, what specifically global data sharing agreement would do? We're going to talk about without global data sharing agreement, counties are able to receive existing CWS CMS data such as case IDs, actually only case IDs, for youth matched against DSCS data. However, we are unable to provide any other data without any county opting into global data sharing agreement. And alternatively, by opting in, a county or tribe becomes party to the agreement and agree to the exchange of confidential and non-confidential data agreement. So it's a two-way exchange. Basically, once any county join, it becomes a three-way exchange. The data that is available from DSCS include, again, medical information, including mental health services, medication information, as well as medical eligibility and payment data. Again, these data are available for any child or non-minor dependent identified as receiving child welfare services. Now I want to demonstrate to you in the slide that you see, it demonstrates what a county will be receiving before opting in and after.
Can you hear us? Can you guys hear us?
Can anybody hear us?
We need to, let me ask the audience. Oh, Pauline Chan says she can hear us. So they can still hear us.
Okay, so we'll continue. So as demonstrated by the slide that you see now, counties who do not opt in can only receive case IDs of the youth who have matched against DSCS data, while counties who opted in can receive all DSCS variables and additional CWS TMS linked data. There are about 23 data elements that we are pushing to the counties that are signing the that have opted into the global data sharing agreement. Now, the process to join in is very simple. It's basically three-step process. There is, I think it's page 16 in the global data sharing agreement that a county would sign, and that's the first step. signed page 16 of the agreement and emailed that to my name, which is akhtar.khan@dss.ca.gov, and then follow up with the requesting and signing the two other documents. One is authorized requester form, and the third document is actual data request form that will get you the data, these confidential data. So far, there have been several counties who have shown interest, and in particular, 4 counties have joined the Global Data Sharing Agreement. Those 4 counties are Contra Costa, San Francisco, San Luis Obispo, and Santa Clara. And 2 counties have already received these confidential data, detailed confidential data, including San Luis Obispo. That's the end of my presentation, and we will open for. Okay, so now this will lead. This will lead into our one of the county representatives on the phone, who will talk about from San Luis Obispo County, their experience on receiving the confidential data and how they feel about this new data.
Right. Ben King, are you on the call? We don't have you logged into the webinar. Just want to make sure that you're here. Can you go ahead and log into the audio, Ben? Can you hear me?
So as we wait for him, can we open up for the questions?
Yeah, we'll go ahead and wait for Ben to call in, but in the meantime, we can go through some of the questions that we received through the chat box.
All right. Question we have was when a county, it says, this is Christina Delf from the medical board. When a county finds a possible issue with prescribing medications, will a referral or complaint be made to the MCC to investigate?
I think we need to do a little bit more research. I believe the answer is no, not at this time. But we'll do a little further investigation, and we can provide a direct answer if there's anything more on that particular question.
Okay, thanks, Lori. Ben King, from San Luis Obispo County, are you on the call now?
I am. Well, I've been on the call. Can you hear me now?
Sure can.
Okay. Yeah, we received a report. It's very lengthy, as it identifies every medication refill through Medi-Cal. So we have upwards of, I guess, 24 lines if a child's on 2 medications solid for the complete year. So it can be a pretty lengthy report. But in this process, it has become very helpful for data cleanup. We've identified a lot of issues with not closing out medications when families go from FR to FM, and then if the kid gets redetained, it appears as if the child never stopped the medication and they're out of compliance on their JV-220. That's just one example. But I've been taking a lead role in really trying to identify all the meds, find out, the status of them. So it's been very helpful for cleaning up our processes, because service components also play a major role in this, because if you don't change a FM case to FR, if you redetain, CMS won't identify that this is an out-of foster care case, and so JV-220s don't show up on there as being needed. So certain things we're finding are very important to the process, because safe measures, it will only show up after that service component changes, and sometimes that occurs at permanent placement from if the parents are now not receiving services and it remained in FM on the service component. So we're finding a lot of little things like that that's really starting to clean up our numbers, and then getting into a process of we're adding another safe measure to our monthly measures about the psychotropic medications when they haven't been reauthorized. So that's a good thing. Challenge is our judge currently right now really, dislikes signing the JV-220s, typically puts them out for hearings, causes this 2-week, 3-week delay where she continues the old JV-220 on a minute order, but we really don't have a new signed JV-220. So we have a gap on some of those. So then that's just trying to figure out a process to rectify that for those periods of time. But we found it very helpful on identifying, because we had one that was 6 months old, case had changed hands. It turns out the child stopped the medications, didn't inform our public health nurse, so it was never closed in CMS. A new worker got it, and then we were unable to identify when the child actually stopped the meds, but we went into this report. We could see the last date that those medications were refilled, so we know it was in that month period that they stopped the medication. So it is very helpful for identifying those issues that are to try to do the data cleanup as well.
Great, Ben. Thank you so much for sharing your experience with the process. Do we have any questions for Ben? If you can type them in the chat box, and we will be happy to ask those questions.
I've got a few questions now. First question is, how many youth are on psychotropics in San Luis Obispo?
Well, right now, and we have 47 kids according to safe measures, and we still have, and one of those is still in a pending, waiting for the signature, but right now we're 47 out of about 300. And then we've also, in our county, designed a separate database to upload all of the JV-220s and have a separate tracking system that we can easily identify every child that's on psychotropic meds with the uploaded JV-220, because they typically only remain in the case file or in a file in legal processing or the public health nurse's file, and it isn't accessible in CMS. So that's really important to make sure that the prior JV-220 matches, all the medications for the current one. So it helps for our public health nurse to review the old one and see, because we're starting to put our public health nurse into reviewing JV-220s prior to submitting them to court, so that we can address dosage issues if there's something that's not right prior to submitting it to court. So, but our social workers are all being trained or have been trained to really go over these JV-220s, really take an effort to ask questions at every contact, at every home visit. How are the kids doing on the meds? Documenting that, because that's been a gap that social workers just allowed the public health nurse to kind of do, and it's really not. We need the social workers to be very aware of what's going on with these medications, what meds they're on, because our judge is asking them the questions. So if they don't know the answers, it looks pretty bad, because really they should know and know whether or not this medication has been having a positive impact or negative impact, and if so, we should be changing the meds if it's negative. So.
All right, we have another question. It's, what are the 23 data fields that are available for counties that opt in?
You can go to that slide.
We'll go back.
This is an example of data elements that have been transmitted to the 2 counties, San Francisco and San Luis Obispo. So the data that's available from DHCS on the Psychotropic Meds project includes medication name, medication dates, and whether or not those medications are antipsychotic. And then the other fields come out of CMS that are linked to those paid claim dates. And this is just an example for psychotropic medications. As we mentioned before, there are other data elements available from DHCS that are not listed here. This is what's already been transmitted via the global agreement.
Okay, the next question we have is, do agencies that opt into the global data sharing agreement have to abide by HIPAA security requirements?
Yes, that is true. That is correct.
All right, the next question is for counties that opt into the global data sharing agreement, how will the data be shared or reported to the county?
So after you opt into the data sharing agreement, we will contact your authorized requesters and make those arrangements with you on the data transfer and whatever specific data elements you request. So that's the kind of the contact you will have with us after you opt into the agreement.
And just add to what Alicia said, right now we have a sort of a template that we have developed, and we are happy to send that data. That has all the data elements we have shown in this presentation.
It's a completed data request form that's been piloted with the counties who received data. It's already completed, so we've tried to make it easy for the counties who are newly opting in.
Next question is, the ACIN reference has an incorrect email address for Mr. Khan.
There's an errata to that ACIN.
We apologize for that, and we have been struggling with it, but an errata was sent. Hopefully all counties received that information and filed it with the ACIN.
All right, the next question, without the global data sharing agreement, the only information is the case number. And they ask, what does the case number mean?
The case number is identifying the use. So it's the 19-digit case ID in CWS CMS.
So for purposes of the reconciliation report, that case ID is just more of a alert that something is going on with that case, where the reports that we're getting from DHCS are not coinciding with the authorization dates that we have documented in CWS CMS.
All right, the next question we have is, if our county does not opt in to the Global Data Sharing Agreement, will the data from our mental health services and child welfare services still be collected and made available on the website?
So on UC Berkeley's website, the only data that we'll have available are the data for the measures that Jennifer went over earlier, and that's the aggregate summary level data. And it's all de-identified data.
All right, the next question is, what does the behavioral health data look like?
Hi, Lynette, are you still on the call by chance?
Let me unmute Lynette.
Or maybe someone else from DHCS.
Yeah, can you hear me?
Yeah.
You can hear me now?
Yeah.
Okay. So the behavioral health data that we, or mental health data that we have at the Department of Healthcare Services, is going to be claims data. So much like I talked about with respect to the lab data as well, it relates to the billing information that we receive about the services. So the information that you receive from us would, as the gentleman from San Luis Obispo talked about, would give you a good basis to then be able to dive deeper in the local arena to look more closely at what the actual detail is behind that claim. So it would give you a starting point, but you would not necessarily want to look at that completely by itself as you're managing the care for these children.
Thank you, Lynette.
Okay, the next question is, the Global Data Sharing Agreement is not higher than local county agreements. And the question is why? That was by Arthur Lomboy.
Can you repeat the question again, please?
The Global Data Sharing Agreement is not higher than local county agreements. Maybe we need some clarification on that.
Yeah.
Okay.
Yeah, if you can please, we will unmute Arthur Lomboy. Arthur, if you're on the call, we'll unmute you right now.
I'm wondering if this is a question about if they have a local agreement in place, does the global data sharing agreement supersede it,
Yes, that would be true. If there is an agreement already between, let us suppose, between a county and Department of Healthcare Services, if they sign global data sharing agreement, that will supersede what they have.
Next question is, what kind of health information, I assume they mean what kind of health information is available through the global data sharing agreement?
So there's a slide that came with some examples. Other than this is medication data, but there's...
Okay.
Am I still unmuted?
Yes.
Yeah.
This is Lynette from Department of Healthcare Services. So the health information, the information again that we have in our claiming system. So we collect encounters that occur under the managed care environment. We have the claims that come under the fee-for-service environment. Both the claims and encounters have essentially the same information, which includes the provider seen, the diagnosis associated with that visit, the procedure codes that may be associated with that visit, the dates, and those kinds of things. So it's essentially billing type information. The difference between the fee-for-service and managed care is that fee-for-service is going to have an amount paid, whereas managed care would not. But otherwise, they're basically the same information. We also would have that kind of information for the pharmacy, for the mental health services as well. So that health information, again, is essentially the administrative data that we receive at the Department of Healthcare Services, and would include information about providers, diagnoses, procedures, depending on exactly the type of claim. And then the pharmacy claims would have the medication information.
Thanks, Lynette.
All right, the next question is, does the data sharing agreement report identify the prescriber's contact information?
Correct. And depending on the data file that's produced, and as has been discussed earlier, we're starting with one data file, but there's the opportunity to develop additional data file layouts in the future depending on what will be most useful. But we do have information about the provider, their address, and such. So as long as that's up to date in our system, we would have that contact information.
All right, the next question is, how many false positives or omissions are you expecting between CWS and CalWIN due to user error or lack of information?
Yeah, we're currently not matching any data to CalWIN, so I think we need some additional clarification.
The only two systems that are involved in this data match are the pharmacy paid claims data and CWS CMS. Those are the only two systems.
All right, the next question is about case ID data. Will it be made available to counties on a quarterly basis even without the global data sharing agreement?
Yes.
Yes. All right.
Well, the case ID only.
Only for the record.
Okay, the next question.
Just want to clarify, the answer is yes for the reconciliation report.
All right, so the next question is, so this is Olivia from the Riverside County Probation Department. You mentioned that this currently excludes probation youth. When will probation departments be required to enter JB 220 information in CWS CMS?
That's a really good question. We're hoping that starts to occur very quickly. Several of our folks here at CDSS have been having some conversations with folks from CPOC, and so we don't have an exact date at this point, but we're working towards finding some kind of resolvable solution so that we are able to provide probation with more accurate and in-depth data.
And the next question is, how often are extracts available to counties that opt into the global data sharing agreement?
So that's dependent on how often you request data from us. And we can set up some regular reports so that if you'd like a monthly or quarterly report, We can put it in our queue.
Yeah, depending on the need, we can adjust the frequency. We can provide it monthly, or certainly we'll probably provide it quarterly as part of the QIP measures.
So this might help clarify. It sounds like once counties opt in, there will be some ongoing direct communication between them and your branch, at which time you can develop some more specific routines for that county.
Yeah, that is correct.
The next question is, if a county already signed the DHCS privacy and security agreement, will those security measures suffice to obtain the 23 DHCS data elements instead of having to start abiding by HIPAA?
What global data sharing agreement makes available for you is matched data that you may not have access to if you have agreement just with DHCS.
Akhtar, this is Lynette from DHCS. I'm guessing that what might be being referred to is we have a specific agreement for counties that are just doing eligibility and are not necessarily receiving the health information.
Okay.
If counties are going to receive the health information, so the information about pharmacy, provider visits, diagnoses, as opposed to just simply the eligibility, then they will need to be under a HIPAA agreement, and we're really encouraging folks to look at the global IA, the global data sharing agreement. And the reason we're really hoping people sign on to the global data sharing agreement, the HIPAA piece is consistent between that and any other data sharing agreement we would have, but under the global, it's specific to the population that we're taking care of. Doesn't necessarily call out specific data elements, whereas most of our data sharing agreements, we call it the specific data elements, and so to change the data being shared, we have to do amendments to that agreement. Whereas under the global data sharing agreement, we've worked out a process to document all data being shared, but we don't have to amend the contract in order to add additional data elements.
Okay. Thank you, Lynette, for clarification.
The next question is, in Madera County, we have an agreement for disclosure and use of Medi-Cal data with DHCS. If we sign the global agreement, would it be more beneficial as there appears to be more data that is returned from DHCS?
Yes, that is correct.
And with the global data sharing agreement, we're not limited to any specific systems or any data elements. So it's a very open, broad agreement. So that's the benefit to opting into the global versus one agreement with DHCS. It has one specific purpose for specific data.
Let's see if there's one. It's will this report exclude undocumented children?
No. As long as they're in the CWS CMS system, they're part of the available data to be matched.
Medicare. Okay, do we have any other questions? I think we've gone through most of our chat questions. Any hand raised?
There's Bill Leach, Craig Steemers, and Grady Howe all have their hands raised. Bill Leach is not on. Oh, Bill Leach is not on the audio, however. So we, if you could just type your question in the question box, we could answer it.
Or Bill, you can email your question to me also.
We have a Rachel Foster with a question. I'll unmute you so you can ask. Okay, Rachel, are you on the line?
Rachel, are you there?
Okay.
As we stated before, we're available to answer any questions that may come up later or that you didn't have the opportunity to ask today by using those two mailboxes that were provided in the beginning of the presentation.
Okay, well, thank you everyone so much for calling in today. I hope this webinar was helpful, and we want to thank everyone for your participation. Have a great rest of your day, and again, please feel free to send any additional questions to those email addresses up on the screen. Thanks so much.